Hello, this is Mark Duke, your instructor. I wanted to provide a screencast just to reinforce, talk about both cases, and to reinforce what was discussed in lab on Thursday. So in case number 1, we have a patient who has a low back problem 5 days ago. So the important thing about this case, and with any treatment that you are providing, is to know that the hard work has already been done by the physical therapist. So your role is, as a PTA, is to pick up that baton from the last treatment, or from, in this case, the evaluation by the physical therapist, and to just move ahead with it. So there already is a physical therapist diagnosis. There's already history that's been gathered to determine why the patient is being seen. So you don't need to ask questions about how they got injured, because it's already here. And I do think it's important as a PTA to know the mechanism of injury. We know that this person got injured while working as an elementary school teacher and getting up from a low classroom chair and feeling a pull in the back. And I think that's important to know. That mechanism of injury was with lifting, and that pain referral pattern is traveling down the buttock and down to the lower leg below the knee. So just as on last Thursday when you were cued, you just kind of move ahead right in that evaluation and to start looking at what is their current problem in terms of functional mobility. So it's bed mobility, marked increase in pain and bracing. So that person is anticipating pain because they felt pain. So they're experiencing increase in pain from moving the supine to prone and rolling to the right. So this is where there's a problem, and a problem in the transfers. Weight shift to the left, understandably, to avoid the loading of the lumbar spine on the right side, and you expect to see some early trunk extension, again that point of pain avoidance behavior. Limited flex, this means extension, just so you know. Limited hip flexion strategy, this is a problem for this individual, and they need some cues to avoid holding their breath. And a marked increase in pain with that transition from a short sit to standing. So you notice these are problems with gait, so you can expect to be addressing all these problems, particularly in the functional level, right? Because these are things this person is doing every day. So really take this in, okay? It's important. Bed mobility transfers, and what problems are they seeing in gait? This is not new information in terms of altered gait mechanics. It's not new information because we studied altered gait mechanics in PTA 132, and you were able to, in lab in 132, understand and learn what a decreased stride length looks like. And this patient is guarding significantly and not moving efficiently because of the anticipatory pain that they expect to experience. So the treatment provided by the PT, your job isn't necessarily at all, and that's really important unless you're told to by the PT to do the exact same thing that they did. Because the patient may be presenting slightly differently, and I think it's important to expect them to actually be moving a little bit differently, hopefully moving a little bit better from that treatment and education from the physical therapist on that first visit. But what you learn is that they're using a cane for joint protection. Ironically, I was just reading an article about how much a cane can avoid that pressure and compression through the lumbar spine, and it actually does a lot more than you think. So there's a good reason the cane was suggested and utilized by the PT to help unload that painful back problem, unload the spine, particularly the right side. Okay, and so here's where it's really important, the assessment. That's that PT diagnosis. Okay, so there's inflammation of the nerve, digestion inflammation, restricted nerve mobility. So there's a lot of stiffness that's occurring, certainly because of the mechanisms of injury, but also because of the muscle guarding. Postural impairment is you anticipate that to continue to be seen the second visit. And again, that reinforcement to PT to use an assisted device to increase walking tolerance. And along with that, if you know from what you read earlier, to help decrease pain. So here's your goals. That's important to spend some time really memorizing these before you walk in and having them down pat. So this is what you're going to be working on. Gait, right? Assisted device on level terrain by 300 feet. Short-term goal, 2 weeks. Decrease pain by 50%. Decreasing pain, that's talking about low back pain, pain altering down the right side, right leg. Goal would be centralization, as discussed in lab, weeks 2, 3, and 4. Postural control, to allow full neutral standing. Think of that as neutral spine without that left lateral shift and that unloading response of that right side. So improving quality of certainly with sitting and standing, but that'll translate over into gait as well. So how do you do that? Well, we talked about that quite a bit, about that drawing in principle, and to utilize the drawing in principle for a functional task. So there you go. And how do you do that? You're going to do that through all functional tasks and make sure that that patient is incorporating those deep abdominal muscles and activating them at the correct time before eliciting pain. So that's where you may need to use some tactile cues to make sure they're turning on the right muscles at the right time. And you also maybe need using some tactile cues to decrease that shift to that left side and to incorporate, make sure that they're engaging those deeper muscles during those transition postures throughout the treatment. And that's really important. This is not a checklist where we check to make sure that we've talked about drawing in those abdominal muscles and you touch them and they are firing at that moment, and then the person, for example, gets up and starts walking and the pain behavior goes right back. The left lateral shift is fully present and they're not loading that right side in terms of weight bearing. So here's your plan. See how they're moving supine prone positioning. Going back to what was instructed by the physical therapist, is it effective? You're going to assess how are they moving and then intervene at the right moment and the right time to incorporate a change in their movement strategies. And stabilization activities. And as we talked about this, we're not talking about simply doing a transverse abdominis pelvic tilt. That's not the goal here, is to incorporate something functional, those stabilization activities with movement or with sitting, activities that a person does throughout the day. And there's different ways of doing that. We talked about some of those ways in a lab on Thursday, but you make those decisions once you see the person moving and see where their deficits are. For example, if that person's having a really hard time getting that leg in position to get ready for sit to stand, you can think about, how am I going to teach them using that drawing in principle to move that leg with less pain, right? And make that correction at the right time, and that in itself can be a possible exercise. It's something they can work on throughout the day. And that's just one example. But it's based on what you see at that moment when you're working with that patient, which is what I think is one of the beauty of being a PTA is making changes that are meaningful for that patient. Okay, so I think we got everything there. You're not going to be using modalities or traction in this treatment, as discussed on Thursday, and I look forward to being with you this coming week to see you provide some excellent interventions for this patient.